So my name is J.R. Marcoux. I received my PhD for studying the structure and function of cannabinoid receptors. Currently the senior scientist at Americans for Safe Access, where I've been a volunteer since 2003. And I'm the research and development director of Green Standard Diagnostics, which is a cannabis laboratory and consulting company. Today's presentation is entitled Cannabinoids in Cancer, Optimism and Healthy Skepticism. So what I'm going to actually talk about today a little bit, after giving you a nice overview of things, is talk about research that shows that cannabis can fight cancer, and the endocannabinoid system actually might be linked to the aggressiveness of cancer. So there are actually two theories that are coming out of the exact same body of research that we're going to talk about. Today, there's a couple things I want you to take home. For those of you who are up on the research, this is pretty well known, but basically cannabinoids like those on the cannabis plant mimic the effect of the endocannabinoid system, or the ECS. So we have these receptors in our body, and the THC is mimicking something that's already there, like endorphins. If you think of endogenous opiates are endorphins, poppy plants' active ingredients on those plants mimic the effects of endorphins. THC is available by prescription, approved to treat two conditions that can be related to cancer: chemotherapy, nausea-induced vomiting, and wasting syndrome. And it's also been used in pediatric studies as well. In basic research models, in a petri dish, you can get cannabinoids to inhibit tumor growth, to inhibit metastasis, the spread of the tumors, inhibit angiogenesis, the formation of blood vessels. And these are done through very specific mechanisms within a cell. There's actually no conclusive evidence that smoking cannabis leads to cancer. Our only information on the subject actually shows less of an incidence of cancer in cannabis using people versus tobacco smokers, for instance. And in some cases, it's about even with people who don't smoke anything. So we're going to go through a quick tour of the endocannabinoid system. I'm going to show you like a picture of a cell. We're going to all start on the same page. I'm going to walk you through very quickly just a breadth of the research done on cannabis in conditions related to cancer, the palliative care. Well, I got a lot of questions about dosing, and I think just going through the clinical studies is a good way to look at all the different ways that you can think about dosing a patient based on published research. And then I'm actually going to talk about what I called conceptual dosing, is we're going to, after we talk about some basic research that I was involved with in glioma research, we're actually going to explore, well, if we wanted to take what was in the petri dish, what does that translate into a human, and does it make sense? That was actually a question that was someone had sent to me. That was a really good one. And I'll end with some stuff about lung cancer risks in those studies, and really wrap up with how cannabis products can be standardized to explore, therapeutic uses more. All right, so this is a cell. It's basically sort of a unit that can have a variety of functions. In this generic eukaryotic mammalian cell, you can see that one thing I like to point out is that it has a surface area, right? It has a limited amount of space to put receptors. And so a change in the expression of proteins on the outside of the cell, which is how it interacts with this environment, can be very important. If it has a lot of receptors for growth on the outside of it, it's going to grow more. This is very important. And the way that those proteins get expressed on the surface, which direct its function, come from the nucleus. And so your DNA is in there, and DNA gets turned into proteins through a number of steps. But that DNA has to get turned into a messenger that gets processed and sent out, and relies on the activity of many things in the cell. So along that way, any number of things could go wrong, resulting in a defect in that protein. Or if, say, you have a defect in centrioles, cell division might be disrupted. So there's a lot of things that can go wrong with the cell. When you look at this, it's fine to think of it as a car engine. Lots of parts that are important for the function of the cell. And these are like a biomachine. They have predictable functions. You can make them do things. So just wanted to sort of demystify what we're talking about here. So we're talking about cells that have specific functions and activities and machinery inside them. And so one of the things that a lot of cells have is proteins called cannabinoid receptors. And the way this was discovered was they used radioactive THC basically tritium labeled THC that was only possible because Meshulam had identified the structure of THC in 1964, which allowed people to basically make cheap copies of THC and spread it around for research. And that's how they discovered that the cannabinoid receptor for THC is one of the most abundant in the human brain. But the cannabis plant isn't actually the only plant that makes cannabinoids. It's the only plant that makes THC and CBD. But cannabinoids have been reported on Vacana africana, which is a tree that makes ibogaine, species of rhododendrons, species of liverwort moss, and chrysanthemums have also been reported to produce cannabinoids. And there's a CB2 receptor agonist called beta-carotene, which is found ubiquitously on plants. If you ate a salad today, or if you do eat a salad today, you'll get about 200 milligrams of it. The endocannabinoid system that cannabis interacts with consists of these proteins called cannabinoid receptors, and two of them, not the only two, are CB1 and CB2. And this also includes enzymes or other proteins for the synthesis and breakdown of the endogenous cannabinoids anandamide and 2-AG. So your body makes anandamide and 2-AG, and it acts on the same mechanism as THC. So what does this system do in our body? It helps us to eat, sleep, relax, and forget, which is a term coined by Vincenzo de Marzo and Raphael Meshulam. So many people might be familiar with the appetite-stimulating properties of cannabis. It has can be sedative-like effects from cannabis, can help you to sleep, has strong anti-inflammatory effects. It also regulates memory. It helps to actually make memories go extinct. And this is a very important part of life, is forgetting things. If I remembered every face I saw from Brooklyn to San Francisco, my head would explode. So it's really important to have a system that's functioning correctly to get rid of information that's no longer useful or harmful. And this is indeed what you can see in conditions like PTSD or other issues, including drug addiction, is where you cannot forget certain things, as well as protect. And this is one of the more newer parts of research, is that cannabis compounds and derivatives of those compounds actually protect the brain and surrounding tissue. They're non-toxic, and we'll show a nice little video of that protective effect in action. And I talked about defects in the equipment, in the endocannabinoid system, in the biomachinery. And these defects can result in decreases in receptor stimulation and activation due to mutations. And this has actually already been proposed in 2004 by Ethan Russo, the clinical endocannabinoid deficiency syndrome, where part of the biomachinery has gone awry, and you're either not making enough receptors, the receptors aren't functioning, you aren't making enough endocannabinoids, or you're making too many endocannabinoids. So, and that's perhaps why some people respond so well to a cannabis treatment, is it's acting like a supplement to their system. I'll give you one example is, if we take a patient who's undergoing chemotherapy, and you give them cannabis, it's going to stimulate them to probably back to a normal level of appetite, right? The level that they should be at. But if you give cannabis to a healthy young person, they're going to eat everything in the fridge. Their system is going to be overstimulated, in a sense, just conceptually to think about that. But I think that the endocannabinoid deficiency syndrome is a way for us to explore the pharmacogenomics, how genetics play a role with developing cannabis-based treatments. So I got a question about THC and CBD, so I thought I'd put together 2 quick slides on them. So THC does have some pain relief effects, bronchodilatory, it's a very strong anticonvulsant. It's actually been shown to be superior when compared to CBD as an anticonvulsant. It is a very strong neuroprotective compound. It's 20 times more powerful than hydrocortisone. Doesn't act through COX-1 or COX-2, and again, in its purified form, it's approved by FDA. This is a little video that shows cannabinoid receptors binding on the surface of a cell, which leads to decreasing the influx of calcium. This might be this is a mechanism of how cannabis treats pain in one form, or perhaps spasticity when you have aberrant calcium signaling. Cannabinoids can inhibit this. Cannabidiol was actually isolated first in 1940 and confirmed in 1963. It does not interact well with cannabinoid receptors. So when you see someone says, look, it binds to the receptor, and you see a huge value, that's not a good thing. You want very, 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 very small amounts of drug to activate the receptor. THC, if you were to move the decimal over to like 4.9, that's where THC is when it comes active. So this is about 1,000-fold less efficient at activating cannabinoid receptors as THC, which is technical speak for saying it does not stimulate cannabinoid receptors. But it is a strong antioxidant. It's also known to be a vanilloid receptor agonist. It can interact with serotonin receptors, and also it can enhance adenosine signaling, which is perhaps how it treats pain. THC and CBD have completely different mechanisms of action, despite them being very similar compounds. Really, the only difference is this in their structure, which is a pyrenic ring, which is thought to be the key for psychoactivity. So if you see a cannabinoid that has this sort of part here, it's thought to be key to the psychoactivity, and also methylating this tail greatly increases potency as well. And I also like to point out, this is the DEA drug code for CBD-rich cannabis. It's a Schedule I narcotic. I know it's scientifically unfair, but if I hear one more time that it's legal to ship CBD-rich material across state lines, I don't know, I'll write an angry letter to somebody. But 7372, I almost just want to change the name of CBD to 7372, because I think it sends a clear message of what state we're in. So I'm going to go through some clinical trials. I'm going to be showing you these massive sort of aggregation of information. And the point is not to read everything on the slides. I think this information will be available later. And there'll be a summary of the clinical trials following it. But what I'd like to say is this research was done for the American Herbal Pharmacopoeia for the Part 2 of the cannabis monograph called the Therapeutic Compendium, which will contain dosing guidelines, treatment guidelines for clinicians based on botanical safety standards. Many early cancer research articles are not available online. State-sponsored clinical studies would seem to be a really interesting thing, not available online. I had to go in on weekends and stuff into records in the basement where no one had ever been at, bats flying out of the bookshelves and things to find many of these studies. So I think that in part has kind of led to some conspiracy theories about the suppression of research just because it's not available online, but it's out there. But again, some of the early studies were really hard to find. So starting in 1975, there was the first chemotherapy-induced nausea and vomiting study, which used oral THC. And generally, they used about 10 mg per the body mass of the patient. And that was pretty much what they did. They did compare it a lot to different medications. And I just want to say this is mostly oral THC, very low plasma levels. But we see that there's quite a lot of research investigating oral THC compared to common chemotherapy, or prior to chemotherapy, but to currently accepted treatments. And it seems to be more effective. And also they've done studies comparing oral THC to smoked cannabis or inhaled cigarettes from NIDA. These have shown to be effective as well. And it was in these chemotherapy-induced nausea and vomiting studies that inhaled cannabis got its first leg up. Because here's the first condition where having an inhaled delivery makes a lot of sense, because people who can't stop vomiting can't keep a pill down. And so in some of these studies, even if they threw up the pill, they were still measured and included in the study, because technically they took the drug. Oral THC, albuterol, smoked cannabis versus a commonly accepted anti-nausea drug. And a lot of times we see both drugs are behaving just as effective. And most of these studies contain anywhere between maybe 30 people to upwards of 200. And side effects, are usually mild. Sleepiness reported. Occasionally you see people exhibiting distortions of time perception. But these are very kind of brittle people who are using cannabis often for the first time with absolutely no guidelines about what's going to happen. Again, we're going through the 80s, lots of studies. Yeah, and this was the most recent one, and I just wanted to show fixed schedule on day 2, and then after 2 days of observation, they just sort of let them take the drug as they deemed appropriate. So if taking oral THC right before a meal didn't work for you, you could take it much earlier to give it a chance to actually have an effect. There's been 9 trials involving almost 600 patients looking at inhaled cannabis, 6 state-sponsored trials, which were done with smoked and oral THC, 14 trials with oral THC dronabinol, 15 trials with nabilone, and generally what's found is that inhalation of THC is generally more effective than oral THC for this condition. And it's oftentimes superior or equal to any of the common antiemetics that are used. Side effects are mild. One of the big reported side effects is intolerance to smoke, which I think is no longer really an issue with vaporizers. But yeah, most side effects were reported as mild. All right, now to the appetite stuff, and we're going to go through this again quickly, but I think it's been good to set the base. We have our first one in 1976, and you see a lot of oral THC being used. And sometimes it's, 2.5 milligrams once or twice daily as the patient sees fit, but we're comparing this to 250 and 750 milligrams of a commonly used drug versus a very, very small, minimal amount of THC. So here's one that's more recently from Abrams, you're probably familiar with. I think it was shown earlier. With smoked cannabis, 1 to 3 cigarettes a day, 3.95% THC, which is something like 38 milligrams of THC. And they started to explore more inhaled cannabis at varying amounts and looking at it compared to oral THC. Looking at sprays of cannabis and oral THC. And this was one I thought was really important. 2007, they gave people up to 8 times the current recommended dosage, and it was well tolerated in a group. But they also looked for people that had had some, even a one-time experience of cannabis in their lifetime. And they were able to tolerate what would be considered extremely high doses in a clinical setting without any negative effects. Or in some cases, even intoxication being able to be observed. And like I said, this is all summarized from basically these 3 articles. This is where the information comes from: Ben Amar, Hazekamp, and Patcher. And so to summarize that, we've actually had 40 clinical trials looking at appetite in cannabis and cannabis compounds. But only 3 studies have actually looked at inhaled cannabis, with about 46 patients, plus or minus a few that dropped out or died. 10 clinical studies involving over 1,000 patients have looked at oral THC. And one thing that comes across in the appetite studies is that you have to take into account the patient's current treatments when you're talking about cannabis, because there's actually some indications that some agents might interfere with the appetite enhancing effects of cannabis. So this is my transition slide, and so we're going to start moving into basic research. I just wanted to hammer it down that cannabis is proven as a palliative care, and I think we all kind of know that in this room, but I thought it was good just to say that there's a huge amount of research on people who have cancer with cannabis. Not to treat cancer, but to treat the symptoms of the treatment and the symptoms of the cancer. And so, in honor of that transition from clinical to basic research, here's a cartoon of God, and he says, "Something tells me this thing's only half-baked." When I first started in working in the research field, I wasn't in the cannabis research field, but I was working with a Native American plant, this creosote bush that grows all over the place, and looking at it for anti-cancer properties. And then, there's a study that made a really big impact. And it was showing that cannabinoids selectively inhibit the proliferation of cancer cells. This was really kind of phenomenal. There wasn't anything available to people that would selectively target cancer cells and leave healthy cells alone. So I started off as an intern in the lab, and they had me watching videos of cells. And so I would count the number of cells that died, and I have one of the videos here. So on the left is normal, healthy brain cells from a human being taken during surgery. On the right are tumor cells. They're given both the same amount of THC, and this is time-lapse over, I think, 40 hours. And you can already see the cancer cells are starting to ball up and die. And the healthy brain cells given the same whopping dose of THC are healthy and moving around.
That's great.
So this is on YouTube. If you search Seth Group, you can find it. So you see things like this. It's very striking. It shows a lot of promise. And so following that study out of McAllister's lab was a pilot study with THC, looking at 9 people who had failed every form of conventional treatment: chemotherapy, radiotherapy, surgery, shamanism, I don't know, everything that they could throw at them. They were fighting recurrent glioblastoma. And when these people were given about a year left to live, the doctors said, let's give them some THC and see what happens. And what they basically found out was that it didn't make the tumors worse. Mathematically speaking, there were no significant results, but compared to people who were not injected at the site of the tumor with THC, the THC group had smaller tumor burdens than smaller tumor volume than the people who did not receive the drug. So it actually was sort of a phase 1 clinical trial showing the safety of the drug in humans.
And Jahan, I think in this study they actually injected the THC directly into the brain.
Yeah, and that's because they could do it without harming healthy tissue, which is not something you could say for any other chemotherapy agent. And shortly following that was a CBD article coming out of McAllister's lab about inhibition of breast cancers through a specific mechanism. And then the project I chose to work on, Sean's lab, was an article that was published a couple years ago called Cannabidiol Enhances the Inhibitory Effects of THC on Human Glioblastoma Cell Proliferation Survival. And so I'm going to walk you through this article. One is because I did the research, so I feel like I can talk about it. And the other thing is it's one of the few studies, I think we finally had one other study published, but it's the first study that has actually investigated synergism between 2 compounds from the cannabis plant and how you might see synergy. And so how do you even start on a project like this? You want to look at synergy combining compounds? Well, you just start killing cells with cannabinoids. So I just started going through the library, THC, CBN, LIN, CP, CBD, CBG, and getting sort of micromolar amounts where 50% of the cancer cells would be inhibited. And this is in a cell line called SF126. It's coded for San Francisco patient 126. So these are all human glioblastomas taken from surgery, cultured, and then used for research. SF126 is actually kind of resistant to cannabinoid-induced cell death. I'm actually going to show you data with much more potent effects, but I like to use this one because it shows kind of a variation in the effects, but mostly, all these are activating cannabinoid receptors except for CBD, but yet it has its own anti-cancer property. So I use SF126, and we also use U251, which stands for human 251, which is a very aggressive glioblastoma brain cancer cell line. On the far right of each of these graphs, the far left, is just basically no treatment, no THC, no CBD, and we just let the cells grow. And you can see in this little figure here, they just grow and take over the petri dish. And what we did is we added different doses or different concentrations of cannabinoids. And so when you add what was determined to be an EC80, so we're looking for, we want to kill 80% of the cannabinoids. So we add that amount of THC. We add the amount of CBD that kills almost 80% of the cancer cells. And we add them together and try and see if there's any additive effects. Then we looked at what's called EC20s, which is the amount required to kill 20% of the cells, and we combine them. These are mathematically determined based on dose-response curves. And the U251 responded really well. And so if you look at this column, this is with no drug, this is with THC, just does a little bit, just knocks it down 25% in the petri dish. And CBD kind of almost doesn't do much. These actually aren't different from control. But when you add these compounds that don't do anything in a specific ratio, you get this huge reduction. And to kind of do a little close-up, here's a confluent petri dish, and this is after 2 days of treatment in the lab. You see a huge drastic inhibition in the cells. And so when you look at synergy, you have to get these combination indexes. And you have less than 1, 1, and greater than 1. And these values less than 1 indicate synergy. The value of around 1 indicates that they're additive, that the effects add to each other. And above 1, there is no synergy. So when we looked at these values that kill 80% of the cancer cells, when we put them together, yeah, we saw some synergy. When we added 20%, what should kill 20% of the cancer cells, we just saw some additive effects. Nothing really to write home about. And then, as we predicted, using 2 amounts that would kill majority of the cancer cells, you get a lot of inhibition. But what was surprising was we could use way less of the cannabinoids by using these amounts that do nothing by themselves. And when you combine them, you get this huge fold increase in synergy. It's pretty surprising, but it doesn't work in SF126, but it works specifically in U251. And so we started to explore this mechanism a little further. And so this is sort of the shore of the molecular mechanism. And so this is a measurement of apoptosis, and 100% is usually what you would look at. And what we can see is that when you add these 2 compounds individually, the ratio, which is roughly a 4-to-1 ratio, nothing really happens. They look like the control cells. No apoptosis going on. But when you combine them, you get a huge increase. So how is this happening? We used rimonabant, which blocks the CB1 receptor, which you might know it as a drug that was pulled off the market in Europe as a diet drug. This has been way more powerful and lucrative as a research tool than it ever has as a medication. It is really an amazing research tool. So we were able to actually block the CB1 receptor, and we saw a little bit of an effect, but we actually didn't see an effect until we blocked the CB2 receptor. And so in the U251 glioblastomas, it appears that the CB2 receptors are a key player. And this, we use vitamin E. And why would vitamin E decrease apoptosis? Well, this is sort of a laboratory parlor trick. Cannabinoids are inducing cell death by creating radical oxygen species within cancer cells. And that was our theory, and so to test it, we flooded the petri dish with antioxidants, and that effectively stopped the effect. When looking at higher doses of just THC by itself versus the combination, we don't see as drastic apoptosis, but it still seems inhibited by application of CB2. Looking at CBD, oddly enough, or not oddly enough, but there is no real effect on its apoptosis effect. So it's obviously active going not through CB1 and CB2 to have this effect. So probably converging within the cell the separate pathways they're triggering. And we're going to go a little bit more into the, so another part is important is what stage of the cell cycle. So cells grow, synthesize DNA, and divide. GO to G1, S, G2 to GM. And what was found was that versus the other individual parts of this combo, you saw a huge arrest right before the cells divide. So as a cell grows, it starts to bud, and so as it's in sort of it's almost about to become 2 cells, that's when they arrest and die. It's a pretty good place. It's sort of at the last possible moment, but huge cell cycle arrest in the G2 to GM phase. And this is potentially through a CB2 dependent mechanism. Now this is like the most exciting part for me for working on the project. And what we found is that in cancer cells, they use this kinase called ERK. They just sort of abuse it to grow. It's a growth sort of signaling cascade. When you apply the combo, we got a decrease in this protein, but not in any other protein that we looked at. Very interesting. What about if we use the individual components of that combination? We do not see a decrease in this important growth kinase. However, if we use the combo, we can see by day 2 in the laboratory that you get a decrease in this activity and cell growth. And in some cases, you can even see it as early as day 1 when compared with 12 hours after the first administration. And so there's a specific mechanism that appears to be triggered when cannabinoids are used in combination in some diseases. And this, I think, really kind of provides mechanistic insight into one possible way that where cannabinoids converge when co-applied. This is some stuff that's coming out more and more, this P8 protein, which is important for signaling apoptosis and things like that. And we saw that THC was also inducing P8 expression, but the combo was also doing it, but they weren't statistically different from each other. So it seems to be THC is also doing this thing by itself involving P8 expression. Another thing that was also interesting was individual compounds do not trigger caspases, and the caspase cascade within a cell. You trigger that, you cause apoptosis, the cells die. And so the combo specifically increased caspases 3 and 7. THC increased 9, but you can see just qualitatively looking at these blobs that there's more of these blobs of proteins than there are in other places. So it's really kind of a specific mechanism. And so to summarize this part, there's a lot of words there, but basically in the study, THC and CBD provide synergistic inhibition of tumor growth in SF126 and U251 cell lines, but not at all in another cell line we looked at called U87. No synergy there. It did kill cancer cells, but it was not synergistic. And this was through a specific mechanism, through the ERK pathway, MAP kinases, and it also led to an upregulation of P8. And so this is just to show you that there is a potential specific mechanism in cancers when co-applying cannabinoids. Another study came out this year that explored a similar vein, basically looking at a 1-to-1 ratio of THC to CBD in animals. And so this is from ear to nose. You can see the little ears there. And these animals are either untreated, irradiated, treated with a 1-to-1 ratio of cannabinoids for irradiation and cannabinoids. And this was not published by McAllister, but by another group. But I thought to include it because it just seemed like a logical next step. And so what they did is they used a mouse glioma model and treated the mice with irradiation. There's a graph to follow this, but this white stuff tends to be sort of the one measurement of the cancers. And you can still see that they're there in all the groups, but less so with the irradiation of the cannabinoids. And graphically represented, you can see here we can just pick kind of the end point and the midpoint, the tumor volume. With cannabinoids, sure, it's decreased. It's less than 30 cubic millimeters in volume. When irradiated, it's not much actually different than the untreated, which is not a good sign. But when you apply irradiation in cannabinoids, you get a dramatic reduction. I don't know if this would be acceptable in a clinic, but I certainly think this is. And so there's another representation, another plot, just to show you where those values lie and where the outliers are. But irradiation plus cannabinoids, super effective in animal models. And here's just another one using our 3 groups, so you can see, I think the hemoglobin and intoxilin staining of the untreated group versus the cannabinoid group, irradiation, and combined really shows you in each group you still have masses forming, but in the one that received both, it was a really drastic reduction in markers related to tumor health and tumor aggressiveness. This is another study about CBD in breast cancer from Sean McAllister's lab. So one of the ways that the breast cancer research was done was by putting breast cancer cells on top of a gel and measuring how well they ate through the gel, their invasiveness. And so this is a measurement of metastasis and other things. And the control, and this is the end experiment, you can see the holes from the plates, but those are, these plates do come with holes that they kind of have to squeeze and claw their way through. But the control cell, you can see all these cells, these little black dashes and stuff and lines are all breast cancer cells. And in the group that received a concentration of CBD, very few get through. CBD can actually decrease the invasiveness of certain cancers. So moving in through dosing on cannabis, and this was again a audience-inspired question, because we hear about, well, what's all these micromolar doses, how is it relevant? And so kind of just to take us back, I'd say let's go back to, medical school, but you guys weren't taught about cannabis in medical school, so I can't really talk about that. But if we had a compound whose molecular weight is 300, and you see 1 molar, that's 300 grams in 1 liter. For instance, 1 micromolar would be 300 micrograms. So we're talking about 1 micromolar. I have to think about that, because we can only get so much cannabinoids in the blood. This red line is inhaled cannabis. This is 140 nanograms per milliliter. And so, does anyone know the molecular weight of CBD? 314. And what about THC? That's a trick question. It's the same. So that was just a dumb joke. But so we take like the 4-to-1 ratio, and we have 1.7 and 0.4 micromolar. That comes to about 534 nanograms per mil of THC and about 125.8 nanograms per mil CBD. I must caution you, while this is the concentration in the Petri dish, there are some subtle differences between a Petri dish and a human that you may notice. One's made of plastic, the other one has a few more integral proteins. But this is actually in the range that you can get in the blood of a cannabinoid. If you take like a typical nidus cigarette, or smoking a 3.8 cigarette results in about 140 nanograms per mil of blood. Conceptually, if you could just keep smoking cannabis and keep raising the amount in the blood, you'd have to smoke a nidus cigarette about 1 foot long to get this much in there. But there's an issue because it tops out at about 150 nanograms per mil, it looks like. But there might be some other factors to increase solubility in the blood and availability. And other questions that are out there too is, what is the concentration of cannabinoids when administered? How much gets into brain tissue? This is a basic question that we do not know in scientific literature. There's some good guesses, but this is actually oral mucosal Sativex. You'll actually see that when sprayed in the mouth and absorbed oral mucosally, you actually do not get any THC in the blood detectable, and that's because it's all going directly into the brain. So it can be a little misleading, and that's why I said that the site of action, the site of the cancer is important. How we deliver it and how we get it there is really important too. So when we think about this and think about dosing, we have to think about, well, that's just circulating in the blood. How do we actually make sure that there's a significant concentration reading the site of the cancer? I mean, it's technically, according to the phase 1 clinical trial we talked about, it's safe to inject it straight to the site of the cancer, but I don't think any hospital offers that as an option right now. So we're going to move in a little bit more to the critical review. It's a very interesting study that came out by Cridge in 2013, and they went through all these different cancer cell lines, and about 1 out of 3, 1 out of 4 studies has shown an increased proliferation when administered a single cannabinoid. Overwhelmingly, it's decreases in proliferation. However, almost all of these studies, all cancer studies, have some flaw. For instance, in the two of the studies that showed increased proliferation, they actually did not describe what the cells were in any way. They just said, oh, we got it from some part of the lung. It seems to be cancerous. Most of the cancer cells that I've worked with are purified, where healthy cells are removed through various ways, and so you have mostly cancer cells there. But you can see in a variety of cancer cells, you can see increase or decrease. This is anandamide, a methylated form of anandamide, the natural endocannabinoid. And it's interesting is pure THC has been shown to increase proliferation. And some of other Schedule 1 drugs like JDOH-133, which is a CB2 receptor agonist, decreases proliferation. It's important to think about this study, and this is used with a variety of cannabis, but yet THC can both increase proliferation and decrease proliferation. It's sort of this weird thing that's going on. So we're still in a phase where we need to track a patient when they're given. And generally, these studies looked at a concentration response curve and saw a trend towards an increase. And you see that even in sometimes when you use CBD in a laboratory, for whatever reason, sometimes the cells grow and other times it kills them. It's an issue to be aware of. So cannabis and cannabinoids are linked to both the suppression and the aggression of cancers. And we're talking about, these researchers have access to the same body of literature. And we're going to talk about the mechanisms of the endocannabinoid system. So generally, in cancers, in a tumor or cancer cells, the endocannabinoid system is upregulated. You have more expression of CB2 receptors on the surface of glioblastoma cells than healthy glial cells. And upregulation supports both hypotheses of having a role in suppressing or having a role in making the cancer more aggressive. And what are the mechanisms to explain that? Well, we've heard a lot about cannabis extracts to treat skin cancers. I think you can find numerous instances of this in anecdotal reports on Google Images. But if you remove the cannabinoid receptors from mice and you try and give them skin cancer, they actually get less skin cancer without cannabinoid receptors. I mean, you would think they would need it to protect them from cancers. But also CB2 overexpression in an animal model of leukemia predisposes to having more severe leukemia. It's a very interesting finding by an animal study. Yet, you knock out CB1 receptors, no CB1 receptors, it increases cancer. So, one hand knocking out the cannabinoid receptors prevents cancer. In another instance, another type of cancer, knocking out the receptor will increase it. So it really depends. It really seems to be tissue dependent, and no one has really sort of sussed out which cancers will respond the best to a cannabinoid therapy. Brain cancer seems to be a really good choice, but it still needs to go. And also, interestingly, in terms of daily dosing, it was asked 50 mg per kg per day in mice reduced the incidence of cancers across the lifetime of the mice. We have the scientific community has identified two things that are linked to THC-resistant cell death, and that is the MDK, the MIDKINE, and the epidermal growth factor receptor ligand anthrareglin. If cells are expressing a lot of this stuff, they're going to have a tough time killing them with cancer cells. This is what Guzman's group showed with the radiation and THC treatment, which I'll mention in a second, but it's basically, these are the markers that a chemotherapy treatment would hit and then make the cells more susceptible to cannabinoid-induced cell death. So in the combo studies, right, I mentioned THC and telomerase for brain cancer. And this, I think, was the first evidence that MDK was sort of the stalwart preventing THC from having a decent effect. You hit it with telomerase, you actually decrease MDK, and you can have a more efficient cannabinoid-induced cell death. They've also looked at combining THC and a pancreatic chemotherapy agent. It's been very effective in THC by itself. Anandamide and paclitaxel combined for gastric cancer. And these are in animal studies, HU210 and 5-fluorouracil, colorectal cancer. And then there's one study on CBD enhancing THC. But these four are pretty much the only ones I could find that describe a cannabinoid and a chemotherapy agent. In all of them, they say that the cannabinoid wasn't really working well. Even something 1,000 times more potent than THC, not really cutting the mustard until you add the chemotherapy agent. And then it's like, wow, it's like these two things do nothing by themselves, but when you combine them, you get this huge increase in efficiency. So the cancer risk. It's a little transition, and I'll be happy to field any questions after the presentation. But so So the cancer risk, right? So you have this innocuous substance that's loaded with antioxidants. It's very safe. And then you do something like this to it. You make it a little less safe. So is there any correlation between cannabis smoking and cancer? There actually hasn't been a correlation to that, surprisingly. I think the best study is from 2006 from Donald Tashkin's group, the government's own lung expert. Looked at 1,100 cases with matching to 1,000 cancer controls. And what they looked at were people who smoked cigarettes, people who smoked cannabis, people who didn't smoke anything. And the people who smoked cannabis and the people who didn't smoke anything had less of an incidence of cancer than to tobacco smokers. And it wasn't a statistically significant difference, but the cannabis smokers had a lower value, a lower incidence of cancer than even the controls. I don't know what that says about the air quality in Los Angeles, where the study took place. Yeah. So mostly they focused on lung cancer, but some of the people who didn't smoke anything got lung cancer, and some of the cannabis smokers got lung cancer. There's just less of an incidence, less of a chance, I guess you could say. But the author said that this may reflect a protective effect from cannabis use. Let's see. And so as I'm going to transition now, I'm going to talk about so where do we go from here? We have these sort of interesting parlor tricks that we can do in the lab to trigger a mechanism. We have some cannabis products out there. Some people are finding success with them, some aren't. Well, why does it work sometimes and why does it work sometimes for patients? And I think it has to do with a lack of standardization. Dosing, administration, product formulation, contamination, adulteration. And so to kind of help us think about this, I'm going to use this cartoon. We have two pigeons. One's skinny, one's really buff. And says, I didn't know they were steroids. My trainer told me they were peanuts. So this points to contamination and adulteration. How do we know that what people are getting isn't contaminating? Maybe, hexane and butane really fight cancer really well, and that's the active ingredient in the hash that people are getting. Sorry, it's a bad joke. But we don't really know, right? We don't have good currently accepted standards are not widely being used by the cannabis industry. And the other issue is even if they find a reliable source, how consistent is the treatment? How far have we come from the caveman days where the doctor said, as soon as the anesthesiologist gets here, we'll get started. So back in that day, treatment varied on the size of the club wielder, the size of the club, perhaps if it was oak or made from a denser wood, who knows. And so this is something I like to think about when I think about medical cannabis dispensaries, is how even if it's called one thing at one dispensary, it could be something completely different. So accurate product labeling and safety of the product, purity of the product, these things need to be established in order to answer some of these tough questions. I mean, how can we develop a cancer treatment from cannabis if what the patients are accessing isn't consistent, or we have no way of knowing if it's consistent, or even verifying the ingredients? I saw a cannabis foodstuff bar in Washington State. And on the front it said, had milligrams of CBD, milligrams of THC, pesticide-free, tested for this, tested for that. On the back it said, this has not been tested by any laboratory. So what do you do with that information? So, however, standards do exist to generate cannabis in a method that would meet botanical safety standards. The American Herbal Pharmacopoeia has published cannabis inflorescence, which that is the technical term for flowers. I try to use it as many times as I can. But cannabis inflorescence by the American Herbal Pharmacopoeia, this sets the standards of identity, analysis, and quality control for growing cannabis to meet botanical safety standards, raw flowers. Actually, in here is Valley Corrals from the Women's Alliance up in Marin on how to do large... Santa Cruz, sorry. I guess my information is dated. But her method of large-scale production and processing of cannabis is actually part of the monograph. You see, the thing about the monograph is it's not intended to price people out. these are standards used in the herbal product and botanical medicine industry. Any reasonable business should be able to follow the standards in here. And I absolutely love the cover because I think it's a great description of where we are with cannabis today. This is a picture of the pot farm at Ole Miss at the University of Mississippi. And you can see there's cannabis growing in the worst possible medium, that is clay, surrounded by a 10-foot tall barbed wire fence with cameras and a guard tower, which is to ensure that none of the cannabis plants escape. They're actually have to ramp up production for the first time to grow CBD-rich cannabis for the state. So the state asked for some huge number, several hundred kilograms of CBD, and the university was now outfitting huge facilities to increase cannabis production there. So with the AHP standards for how you, for purity of cannabis, the American Herbal Products Association has actually issued recommendation for regulators, best business practices for cultivation, processing, manufacturing, dispensaries, and laboratories. And one of the things I do through ASA is I actually audit these facilities based on criteria from APA. And APA didn't just come up with this stuff in some smoke-filled room in Las Vegas. It was actually done with, this represents over 300 to 400 trade groups that deal with botanical medicines, herbal supplements, and people. There's an open invitation to people from the industry. And many dispensary operators, manufacturers, laboratory people came and participated in determining what would best practices be for each of these operations. So it's industry standards set by the industry, approved by a trade organization. There's nothing like this right now. And so, just to recap, AHP, purity, identification, proper packaging, and storing. You take AHP and you take APA, you get PFC, which is patient-focused certification. It ensures compliance with the standards set forth by APA and the AHP, also with the local regulations in the state. Involves a physical audit. I go there, I go through all their paperwork, I make sure that the place is clean, that they're not using, and you know, something like Eagle 20, which is a systemic fungicide, if that was found anywhere in the facility, say of a cultivation site, it would disqualify it as something that could be of safe botanical medicine. It's actually against APA standards. Just to give you an example, it involves one annual surprise audit. We go through all the staff training and documentation. You can find out more about here. And what this does is it puts a label on the manufacturing, dispensing, cultivation, or laboratory reports and products that come out of there. And so as a doctor, you can't tell people where to get cannabis, but you can tell them to look for a seal. You know, if you have this seal on your product, you know that it's following basic safety and handling protocols for botanical medicine, that the readings from the lab are going to be within acceptable limits of accuracy. And so I think it's a very powerful tool that's coming online now. I've done audits in about a dozen states. I've been in about a dozen facilities in half a dozen states. This is more information about it, just to demystify for you. It's a nonprofit third-party certification. And almost all certification for any industry in this country is all done by third party. Does the FDA certify somebody organic? No, they say go and choose one of these 300 companies, each with their own level of stringency. Kosher's the same way. Kosher, sometimes some guy just has to visit your facility. Other times the rabbi has to live on the premises where the cheese cracker is made. You know, there's varying levels of standards. And I just want to point out that, you know, FDA does not, certify places. They punt it to third parties that are often established by the very industry they're trying to regulate. And so this is actually not directly part of Americans for Safe Access. It's part of a foundation. All the money that the places pay to be audited goes into a foundation. No one can touch that money, but when there gets a threshold is reached, you can apply for research funds to actually do research through that foundation. So the hope is in 3 to 5 years, the foundation will be funding research that the industry is providing. And like I said, these standards are based on APA and the AHP. We also have online courses from the Cannabis Training Institute. I'm just going to take, just to end with some 2 or 3 stories about auditing. Most places, the most common corrective action is adverse event recording and reporting. This is actually in one of the top 10 things I say to people who have questions about getting CBD for their brittle children, is ask the company if they have a recall plan or if they have any sort of adverse event recording. Security, the requirements for security vary widely between states. Some states you're not even like, they don't even want you to have a security guard. Like Washington, they don't want big burly guys being the gatekeeper. In Washington, D.C., you need to hire a retired cop or someone who's a member who has prior police experience to work at the dispensary. Completely different regulations. And I'll use D.C. as another example for waste disposal. And this is not actually too far from what their law says right now. Basically, after a certain amount of time, cannabis on the shelves has to be put to a white box at the dispensaries in Washington, D.C., which is then picked up by the police and taken somewhere. Probably to the police department. Whether it's put in an evidence locker or an incinerator, nobody really knows. And this came across in the audit because one of the major things in the audit is if they're disposing of their waste, cannabis waste properly. This is really important for laboratories as well. And so what do they do with their moldy cannabis? What do they do with their bud cannabis? But when I asked them for their waste disposal records of how much the police had picked up, they had none. They called the police department. The police department refused to give them the information or even tell them whether or not it ever reached there. So my solution to their waste disposal problem was to fill the box with cat litter and or bleach and put the cannabis in there and see if the police officer's mood changes. So that was, but that's kind of how these audits work. That was sort of a nice, lofty, fun description, but waste disposal is a big issue. You don't want to throw away dangerous product into an easily accessible trash can. The rules and requirements also differ from state to state. If you're at a dispensary, you can't give people advice about how to use cannabis if that condition is not allowed in your state. I'll give you an example. Pennsylvania just tried to pass a law this year, a cannabis law, where glaucoma and AIDS would not be recognized as qualifying conditions, but chronic pain would be. In New Jersey, glaucoma and AIDS are recognized, but chronic pain is not. And those states are just one bridge apart from each other. And so qualifying conditions differ from state to state. Lou Gehrig's disease isn't even recognized. I think it's only recognized by 10 states as a qualifying condition. So this is kind of a very interesting time right now in the certification of the industry. It's the only certification I know of that is out there. And so this is actually how GW Pharmaceuticals standardizes their cannabis extract. And I love to show this slide because it really kind of lays out what's involved in this QC process. You have your THC-rich plants and your CBD-rich plants. You cure them in a facility. As you may be able to see, there are no McDonald's wrappers or trash on the floor. They're very clean facilities. And each of these things is an HPLC. And you can see that they have checkpoints at each time. So after the cannabis is harvested, they test it. Before it goes into the CO2 machine for extraction, it's tested. After it comes out, it's tested. What a wild idea. You might want to know how much you're supposed to get out of the extraction process. So far, I know of no laboratory that does CO2 extraction that actually measures it before it goes into the machine. You have no idea about the efficiency of extraction. But they get their nice, thick, gooey hash oils, and they measure those after they are sort of collected. They add a little bit of a sprig of mint for palatability, and then once it's encapsulated and stored, they test it again. So the QC process is a little complex, but I think it makes a lot of sense. Before you do anything to it, you should test it and make sure what's supposed to be there is there, and that so this is more related to manufacturing audits, but just sort of demystify what a good QC process looks like for quality control.
Where is this?
That's GW Pharmaceuticals in Britain. So to summarize most of the research we talked about today, combinations and botanically derived substances, mixtures of cannabinoids, appear superior than single cannabinoids. There isn't a report of a combination of cannabinoids spurring proliferation. There's only reports of single compounds. Radiation and chemotherapy have been shown to increase the sensitivity to cannabinoid-induced apoptosis. So we've talked about MDK and the EGFR ligand that are linked to resistance. I know this is kind of a strange word, meaning cell death, and I probably should have mentioned this earlier, but I think it's fascinating. The word ptosis is, I believe, it's a Greek or Latin word that comes from the changing of the leaves in fall when they dry up and fall. And ptosis is also a condition of the drooping of the eye. And so that's, when you think about apoptosis, I like to think of it about leaves and the falling of the leaves and this sort of programmed death. A very great word that's mispronounced all the time. Cannabis is proven to significantly help with side effects of cancer and related treatments. Cannabis may have some direct anti-tumor effect. There's definitely less incidences of cancer in user populations. Does cannabis cure cancer? Well, if that were true, Bob Marley might still be here. Apparently his cancer was not completely susceptible to cannabis-induced cell death. Dosing. This is a big problem with standardization of treatment. This is a tangent to epilepsy, but I think it's really important to mention that brittle children suffer when products aren't standardized. So physician Ethan Russo, who was a pediatrician for a while, had treated kids with epilepsy. He gave very specific instructions that the kid was to get the name brand drug. But the pharmacy, after the kid was on the drug for a year, gave it generic treatment. And the generic version had less of the active ingredient than the name brand version. And the kid started having refractory seizures again. Just not because the medicine wasn't effective, but because the dose of the medication changed. And that was enough to have a relapse in symptoms. And so when we're thinking about treating brittle conditions with cannabinoids, I think standardization is really important. And once we have standardized products, that could change the world. So thank you, SCC, for having me. The research was done primarily in Sean McAllister's lab. Here are the grants that funded it. Thank you very much.